We are your hosts, Nikki Shore and Jesse Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, APIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Hello, and welcome to podcast number 43. And today we're going to crunch a bunch of numbers and bust some myths about infection prevention staffing. And speaking of numbers, Jess, why did the math book look so sad?
I don't know why.
Because it had too many problems.
And yet here we are solving one of the biggest problems in infection prevention, staffing. Let's just hope the solutions don't come with any calculus required, Nikki.
Yeah. No long division here, Jess. No long division here. But we are talking about a calculator that is so smart, it is practically the valedictorian of infection prevention. And to walk us through it, we're joined by two experts who are talking about their article, Closing the Gap on Infection Prevention Staffing Recommendations, Results from the Beta Version of the APIC Staffing Calculator.
Well, I'm very excited about this conversation. And first, let's welcome Dr. Sara Reese. Sara is the newly appointed Director of Research for APIC's Center for Research, Practice, and Innovation. Sara has done it all, from leading COVID-19 responses to mentoring MPH students. Sara, are you secretly a superhero, or do you just never sleep?
Maybe a little bit of both.
Welcome. And let's not forget Dr. Becca Bartles. Becca is the Executive Director for APIC's Center for Research, Practice, and Innovation. Dr. Bartles has spent 19 years making infection prevention smarter and safer and, yes, even cooler. Becca, I hear you're also the mastermind behind an academic pathway program and a staffing calculator. So my question is there anything that you don't do?
Oh gosh, I don't remember to send birthday cards in time ever. So
why don't you go ahead and say happy birthday to everybody right now?
Yeah, right.
Entire year covered.
Exactly that. Yep.
Plus, Becca is the proud mom of 4 daughters between the ages of 10 to 25. So basically, she juggles infection prevention and family like a pro.
That is a lot. Mm-hmm. Well, Sara and Becca, we're very, very happy to have you guys here. But let's push all that other stuff aside. Let's kick things off with the big question. What inspired the need for a smarter, more nuanced staffing model in IPC?
So this has been a long time coming. I think anybody that has spent any time in infection prevention knows that our algorithms for staffing have just not caught up with the progress of our profession. We've utilized a staffing ratio as our primary method for staffing IP departments since really IP began, back in the 1970s. And although that ratio has changed over time, it doesn't account for all of the nuance that really is our job. And so the idea behind the calculator is to boil the ocean, really, but to make a very simple tool that folks can use to estimate and understand all of those external or internal risks as they build their own staffing model.
That's great. Let's talk about the beta version of the calculator. I'm guessing it's not just Excel on steroids, right? How does it differ from our old school 1 FTE per 100 beds ratio?
So the calculator uses, maybe it is Excel on steroids. I don't know, but it's a little more complex than that. But the idea behind it really isn't all that complex. So we list out a number of questions, and each question represents something that may take more infection prevention resources and time. So things like, does your hospital have a rehab unit, a burn unit? Do you care for transplant patients, et cetera? And we try and target those specific things that an IP may do in their daily work that we know are going to require more resources. And then we adjust the number of beds in the staffing ratio to reflect that. So, back in the 1980s, our staffing ratio recommendation was like 1 IP to 250 beds. And just as you just said, more recent literature has put that range anywhere from 1 to 69 beds to 1 to 100 beds. We started in the calculator with a baseline of 1 to 85 beds, just kind of finding the midpoint of that literature. And so for each question that you answer, the number of beds in the ratio either goes up or down. So if, for example, you say, I do not have or I do have a burn unit, then the calculator will add 10 beds to subtract 10 beds from the ratio. So you go from 1 to 85 to 1 to 75, meaning you have increased staffing needs.
Wow. And, one other piece that I appreciated was that it also takes into consideration ambulatory spaces, which is often not taken into consideration, but we're expected to engage with and, do infection prevention work in those areas.
Yeah, I agree with that. When you get hired onto the hospital, usually you embrace the acute care side, and then it's like, well, let's go visit physical therapy or all these other outlets. But I love that it incorporates variables like ICU presence and case mix index. So can you explain how those refine staffing recommendations and why stop there? Are there any other facility-specific factors that you'd want to see included, and including some of those ambulatory aspects?
Sure. Yeah. So, the algorithm looks a little different on the ambulatory side of things because, we can't use patient beds as the part of the ratio. So we utilize number of clinics. But again, the access to resources, things like, is there a surveillance system in place? Those all increase or decrease the ratio.
Let's also talk a little bit about outcomes. So what is the correlation between IPC staffing levels and improvements in hospital-acquired infections like CLABC or even C. diff?
Right, yeah. So that was what was really cool that came out of the data analysis from this beta version of the staffing calculator. We had the IPs enter in, when they were filling out all their information, their standardized infection ratio, their SIR, for CLABC, CAUTI, C. diff, SSI, for the last year. And so when looking at that data, though, it was kind of variable in how they put it in, and it was unclear if 0 meant 0 or 0 meant they didn't have enough to calculate an SIR. And so with that, we decided to make sure since this analysis was so important, that we wanted to make sure the data was as accurate as possible. So we ended up going to the CMS website and pulling all of the SIRs for the CMS reportable infections to give us that was our outcome to compare to. And it was really cool because what we found was that when the calculator spit out, it would say that if a hospital was below expected with staffing as expected or above expected, and then we compared those that were below expected and how their SIRs for the CMS reportables were comparable, I guess. And so what we ended up finding was that if you were reported as below expected, you were significantly more likely to have a high CLABC SIR, a high CAUTI SIR, high C. diff, and high COLO SIR. And so and this is the first time this has ever been demonstrated in the literature. So to be able to have this many hospitals and data we truly trust, since it's the CMS reportable data, to really draw that correlation is incredible. It's awesome, and I think it'll carry a lot of weight in what we're trying to do here and provide appropriate staffing for our IPs and healthcare.
Yeah, that's excellent.
It is excellent. And I need to ask, did you uncover any other unexpected gems when you were analyzing smaller hospitals versus larger systems? Like any underdog success stories of the IP world?
Yeah, that there was quite a bit of a aha moment for us there as well. I think some of these moments really kind of seem like duh moments, right? Like we all kind of knew that the answers to all of these questions, but we never really had the data to support it. So one of the things we learned about smaller facilities, particularly critical access facilities, is using a ratio doesn't really give us that understanding of what is the minimum number of FTE that is required to keep the lights on in a healthcare facility, regardless of the number of beds, the size, the programs, anything else. Just the basic housekeeping stuff that an infection preventionist does at any, within any healthcare setting. And when we look at the numbers in those very small hospitals, it's looking like, that there is sort of a baseline there, and we're thinking it's about 0.6 FTE is really what's required when there's no other risk factors and the beds are small, and then we build from there. So it's a bit of a spoiler alert to what's coming in the next version of the calculator, but that part of the algorithm will be rebaselined.
Yeah, I can definitely appreciate that. Thinking about some of the critical access hospitals that are part of our hospital system and the work that is required from those infection preventionists. And typically what we've seen has been that we have a 0.5. So I think they could probably use that additional bandwidth. And so looking to the future, what exciting updates can we expect in the next version? Maybe it'll come with a button that orders us Starbucks.
Right. As
need the
exciting
caffeine.
as that would be. We all can start the day with a good cup of coffee, but sadly, no. But we are excited about the next version and are currently building it right now. And I think what's really cool about it is with this revelation about the different needs in the smaller hospitals versus the larger hospitals, the baseline is going to be different for each for different size hospitals. So when the calculator user goes in, they can enter what size hospital they have, and it'll take them down a specific algorithm. So if they're smaller hospitals, then they get questions somewhat like, do they have an ICU, or do they have an ED, or do they perform surgical procedures? Something that you don't see in every small hospital, whereas you're going to see this in every single large hospital. Of course, they have an ID, of course, or ED, of course, they have an ICU. And then beyond that, we're going to ask, more detailed questions and apply more kind of weight to different responses. So looking at previously, we just had asked if they have an inpatient rehab or a burn unit or a stem cell transplant unit as one question, and then apply a weight appropriately. But what we found within our analysis is that with those questions, a burn unit has specific needs, a stem cell transplant unit has specific needs, a rehab has specific needs. And so we need to be able to take that into account, not collectively, but individually. So those questions are divided out. And we're also doing a little more digging on what else does staffing impact. And so this is something I'm super excited about because it's the outcome piece that I think is going to be fascinating. Hopefully we find something, but we're trying to get at what was in your last Joint Commission survey, what number of conditional level findings did you have in the infection control chapter or the EOC chapter that directly impacted infection control work? Because really IP staffing, outcomes, reportable outcomes, 100%, we're going to impact that, but we impact the whole hospital and not just those outcomes that are reported to CMS. And so to look at, successful Joint Commission surveys and staffing, or to look at, the number of ICRAs that our IPs have submitted in the last year of type 4 and 5 that are taking a lot of time, or even looking at the CMS surveys and how many citations or conditions of participation have occurred, because those IPs, if you don't have the appropriate staffing, you can't get out there and prevent infections. And then, of course, that is when you end up getting in trouble with citations. So it's, it comes down to we fine-tuned the calculator with the previous version, and now we're taking it to the next level and digging a little bit deeper and trying to figure out what else we impact and the outcomes that we can get from that and draw those associations.
It's so funny because I immediately thought of the Joint Commission findings when you said considering other outcomes. And I'm going to throw you a little bit of a curveball. I'm wondering if, this is because of a personal situation, but I'm wondering, have you considered how the experience level of the infection preventionist might weigh in on the number needed as well? Just like having a lot of inexperienced IPs, I imagine, makes the work much more challenging for them.
That's an interesting question. So you're basically trying to take experience, right, Jess? You're trying to factor in experience into the calculator.
And how do you do that?
Yeah, that's good. Good question.
Yeah, I think in the very early versions, we did have that question in there, and then we decided to not take into account, just because there's such variability when it comes to experience, professional background, and I think the confounding factors that come with that we wanted to not take that into consideration, just due to the complication of trying to tease out what does experience mean, and how do you incorporate that into outcomes. I think it's a great point. But I think at the level that we're trying to get this done and completed and have accurate data to put in and get out of the calculator, I think experience just has so much variability that it may not be as useful of an information as we would like. Becca, do you have any additional thoughts on that?
Yeah, I think, it's important for us to share too. Like, this is a very iterative thing. We're working on version 2 right now. Version 2 will not be the final version. And we will continue to ask investigational questions within the calculator, and then utilize those in each additional version, each optimization. So, I think there is a future state where we're able to dive in and get that level of specificity, and maybe even produce ranges, based on experience, that sort of thing. But we're not there yet. And, this jump from version 1 to version 2 goes from 1 algorithm to 16 algorithms, just in adding in, the hospital stratification that Sara talked about. And we're adding in, we've been working with Shay to put some baseline numbers around medical director support. And so we'll be putting that in the new version as well. And so that adds a layer of complexity. We're going to roll that out, do another analysis with all of the new investigational questions, and then, you can expect V3 following that.
This Fantastic. Is such a cool, amazing tool. And I think it's almost like I'm trying to visualize how it's going to look. Like, it almost sounds like you can print off a report about everything that goes into what your facility should expect from an IP. And maybe that answers the question, but how can we use this? How can IPs and healthcare systems use this to make a strong case for resources at the executive level? Let's get those green lights.
The $1 million question.
Yeah.
Yeah. I mean, I think the fact that this paper's come out and the association has been drawn between increased infection rates, especially reportable infections, and staffing, I think is going to carry a lot of weight in that executive suite. And those conversations, the IPs need to be able to get that information in front of those executive leaders and have that conversation. And I know I've heard from some IPs that they've been successful with this information at their fingertips. However, I think in the future, as we continue to refine this calculator and make it better and better over the next few years, I think then we get to the point where we start having systems that are utilizing it, and we have executive leaders that can, go out and advocate for it. And because right now it's in a state where APIC IPs are saying this is how many IPs that you need in your hospital. It almost sounds sadly self-serving, but it really is what it is. So once we get it out there to the point where people are using it, people outside of just our community, and we get partnerships with Shay or the CDC, to really advocate that this thing is real, this is legit, this makes sense, and you guys should really be looking at this, then I think you're going to have much bigger conversations and more serious conversations about staffing.
Yeah. And ultimately, we would like to see this, written into legislation, and, or have our regulatory organizations, our accrediting organizations require at a minimum that we either utilize the staffing calculator recommendations or a comparable, needs assessment that takes into consideration a number of factors.
And One more question for the dreamers like myself out there. How do you see this changing IPC staffing practices beyond acute care settings? So we talked a little bit about ambulatory settings, but what about long-term care or even public health?
Yeah. So we do have a calculator out there for skilled nursing and long-term acute care. We've had very little uptake in usage of that. And so not enough data at this point for us to really analyze and move into like optimization work. So we're pulling back on those, and we're going to pivot to focus groups and then potentially re-release with hopefully some assistance with other associations that are more active in the long-term care field, because it's important we get it right. That's probably, long-term care specifically is probably the most underserved of all of the care settings when it comes to infection prevention. They have the highest rates of turnover, the least experienced staff, et cetera. So it's important we get it right. But it's a bit of a different process since folks that are working on their staffing recommendations probably have significantly less resources than hospitals would.
Yeah.
So, Dr. Reese and Dr. Bartles, you have given us a lot to think about. And I want to thank you for making infection prevention staffing sound manageable and kind of fun.
And for our listeners, don't forget to check out the APIC article and play around with the beta calculator. Who knows, you might discover your hospital's been understaffed this whole time.
Ladies, before we let you go, any final thoughts that you want to send us off with?
I would love for everybody to take a look at APIC's research agenda that we published back in September. You can find it at apic.org under research, and it lists comprehensively all of the areas where we've identified gaps in infection prevention research, and we're hoping to address them. And it's really a call to action for anybody interested in doing research in this space. So take a look at it.
Fantastic. We're excited to see more coming out.
Yeah, we definitely are. This is really, really neat. I think our listeners are going to agree. And I want to thank everybody for tuning in to podcast number 43. Until next time, stay curious, keep innovating, have fun, and keep washing those hands. That is a wrap. Thank you for joining us today. We are Nikki Shore and Jesse Swain, and this is the American Journal of Infection Control podcast, Science into Practice. Thanks for listening and doing your part to prevent infection, because remember, infection prevention is everybody's business.
APIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Center of Research, Practice, and Innovation, and Pat Stone and Jean Brandt at APIC and APIC staff, Rebecca Bartles, Ria Gupta, Bobby Gulshan, and Liz Garman. We work in partnership with Human Factor and audio techs Blake Alton and Carolyn Schneer. To hear other APIC episodes and to access information about this podcast and the field of infection prevention and control, go to our website, ajicscienceintopractice.org. That's AJIC scienceintopractice.org.